Guys, I'm sure all of you know Yoko Morotel. He's a dear friend for years and years, and he's from Germany, from Hamburg, and we have done lots of workshops together, trained lots of people together. He specializes in endoscopic surgery, has worked with some interesting people during his career, and he can't get his screen to share.
No, I have to screen. Wait. Now I'm here. Should be fine now. What do you see?
Oh, it's okay. We have general information. Good?
Yeah, good. Wait, I have to bring this on a full screen, right?
Imad, can you help?
No, I don't see. The problem is that on this small screen, I don't see the. Wait. Okay. So this is you see this now?
Yep, we can.
It's a recently done case, actually 3 days ago. And it's a female lady, 62 years old. She had a short history. She presented with some gait ataxia and numbness in her right face. And well, obviously we did a micro endoscopic procedure, and this is the images.
Okay, you want to ask people what do they think it
with
is?
Contrast.
You want to ask people what do they think it is?
Yeah, what do you think it is? It's T1 with contrast, and I have a T2 in the next slide. T2 without contrast. This is axial, this is sagittal. So you see it's in the pons area. There's a lot of fluid here. There's some solid stuff here. There's a lot of fluid here, some solid stuff here. And when we go back, you see some contrast enhancement in this area. And this is here, some fluid in the pons area.
Okay.
So what do you think it is, and what would you do?
If anybody wants to answer, please raise your hand and we'll switch on your mic. So the question is, what do you think it is? And what would you do? So first question, what do you think it is? Any takers? Come on, guys. We have 177 people here. Who wants to take this? Adnan Khalik, do you have any idea? Shall I unmute you? Let's see.
What's the differential diagnosis of lesion in the brainstem?
Hello, assalamu alaikum, sir.
Yeah.
I think the images shows some intraaxial lesion in the brainstem. Probably it is a pontine brainstem glioma, and it has a solid cystic component. So most likely it is a pilocytic grade 1 glioma.
Okay. So what is
Yes.
And not in favor of the diagnosis of a pilocytic astrocytoma?
Sorry, sir.
What is not in favor of this differential diagnosis?
Patient
is 62
has.
years old.
Yes.
62 years old. It's not that you cannot have a pilocytic astrocytoma symptoms, but it's rather unlikely when it's at that age to develop symptoms. And
Yes.
very short history.
Yes, sir. Yes.
Just a couple of days history.
So
Another differential, but it's not pilocytic. What is the most common cause for intracerebral hemorrhages?
Okay, we have Hafiz Nimr. Where are you from?
I'm from Palestine.
Okay, Palestine. Great. So tell us, what do you think it is?
Maybe it's a hemangioblastoma, because there is
hemangioblastoma. I think it's a good idea. I thought it might be a hemangioblastoma. I have to tell you it's not, but I agree with you. You see here a solid part. So this could be the nidus. And then you have typically a hemangioblastoma cyst around it. The thing which is a little bit against this is that this cyst here is not the same color as a CSF. Usually hemangioblastoma is light cystic color, but would be possible. And also the contrast enhancement is not very sharp. It's a little bit unsharp. So, but hemangioblastoma I think is a good idea. But it was not.
Farhan Gulzar wants to say something.
In hemangioblastoma, normally we see there is a flow void in it, a vessel. We can see it. I can't see a vessel in it. It could be a
Flow
cavernoma because
void.
it has
Why
a
should
bleed
you
with it.
see flow void in hemangioblastoma?
In hemangioblastomas, there are
Why?
vessels in it, and in the nodule, it has a vessel in it most of the time.
I don't agree
Okay,
with
so
this.
we go to Khalid.
I think
Ashur.
it's a
Very
cavernoma.
small nidus, you barely
Yes,
see vessels in many cases.
Okay, I think regarding this lesion, we're taking in consideration the age of the patient. We'll put a hemorrhagic metastatic lesion as
Very good idea. Very good idea.
a differential diagnosis for this. She's 62, and maybe due to melanoma, maybe due to renal cell carcinoma as a primary. So
Yeah, this was our first differential actually during the time. So this is rather against surgery, right? If you have a suspicion for metastasis, which an hemorrhagic metastasis in the brainstem, it's unlikely to proceed for surgery. What is against metastasis? There's no edema. There's absolutely no edema. You see that?
That's right. Yes.
So, but it's like hemangioblastoma. I think it's a good differential diagnosis.
Right.
So one more. What is another option? Glioma with hemorrhage. Okay, I would not go for pilocytic, but maybe a malignant glioma. Maybe sometimes pilocytic can become malignant. They tend to bleed, but it's rare. And then,
Okay,
of course,
anybody
I
else?
think it's a.
Sorry. Go on, Joachim, go on.
No, any other options?
Anybody else giving any options? Okay, we have Hafiz Neymar again.
Cavernoma.
Yes,
Cavernoma.
Cavernoma of a hemorrhage, huh? Yeah,
Yes.
I think
Okay.
it's a good option. Good option.
we have another person here, so let's see what he has to say. It is Francisco. Where are you from, Francisco?
I'm from Mexico City.
Okay, Mexico City. Yeah.
Could be maybe a big
Can you speak a
aneurysm.
little loudly, please?
Could be an aneurysm.
Well, aneurysm. The only thing which is against aneurysm is that it's really purely in the pons. It's not. There's no contact to the subaortic space, so it should be not in contact to any vessel. But could be like an angioma with an aneurysm, something. But when we look at the images, we don't see any vessels in this area. Okay. So now next step, what would we do? What do we do now? What is the next step? We have the differential, let's say the most likely ones. Forgive me if I just take the wrong ones, but metastatic lesion, let's say cavernoma, let's say hemangioblastoma. So very mild symptoms. What is the next step?
Ali Ahmed is here. Where are you from, Ali? Ali, where are you from? I think Ali raised his hand, is busy with his kids.
I don't hear her.
Yeah, I think.
Okay, so what do we do? What is next? Do we need more diagnostics? We need more. We go for more observation. We go for surgery. What is the next step to decide how we proceed?
Okay, any takers, please?
So, anybody? What would you do? Would you just follow the patient? Would you do more images like CAT scan? What would you do?
Okay, why do you want to do a CAT scan? Okay, we have Francisco again. So let's see what he has to say.
Maybe we could use another view of the MRI, maybe a SWI, to see if have hemosiderin, or maybe an angiogram, an angiography.
There's a little hemosiderin rim. You might not see it very well here. A little bit darkish. Angiogram, I think, yes. If you think about angioma or aneurysm, I think angiogram would be a good option. Actually, we have not done angiogram, so I cannot show you anything.
Really, I think it's
But I think it's fine to do it with a complete workup before you decide what to do with this case angiogram.
Okay, any other test you guys want to do? Anybody? So we said there's a little bit of blood there. So what's the thing that can give rise to blood around the lesion?
Okay, so we have the suspicion for hemorrhagic metastasis. So I would recommend to do a CAT scan of the lung and the abdomen, right, to rule out any primary cancer. What do you agree? I mean, this would be an option.
We have Khalid Ashur. Khalid, where are you from?
Yeah, I'm from Egypt. I'm working in Saudi Arabia.
Yeah.
And I think if I follow my suggestion that it may be a hemorrhagic metastatic lesion, so we have to go and do scanning, metastatic screening. We'll do a CT chest, abdomen, and pelvis for the patient. We may need to do a clinical examination to the breast, whether there is any lumps, any lymph nodes, supraclavicular, axillary, inguinal, and also if we put in mind that it might be renal cell carcinoma, so if we put in mind that it may be a hemangioblastoma, so we should search for pancreatic lesion, for renal cell disease, for renal cell carcinoma, retinal examination to detect any hematomas. So these are the things we want to complete so that we can find out and reach a diagnosis for the case. And I think we have time because the patient is asymptomatic. So we can do this.
It's not asymptomatic, it has gait ataxia and some numbness in the trigeminal nerve area, but that's it.
Okay.
Okay, so I agree. I think if you there's a suspicion for metastasis, I think we should do a cancer workup. We can send the patient for gynecology to set up. We can do abdomen and thoracic CAT scan. If you have abdomen and thoracic CAT scan, I probably would not further go for the Hippo-Lindau syndrome to work up at this stage, because if you know that this patient is a Hippo-Lindau patient, does this really affect your decision what you want to do? I don't know. Anyway, so we have done all this and everything is clear. What is next now? She has no evidence for any primary cancer and no renal cell carcinoma and no lesions in the retina and so on.
Okay, we have Peter from Indonesia. Let's see what he wants to say.
Peter?
I can't switch his mic on for whatever reason. Now its mic is on. Yes, Peter.
Oh yes. Good lecture. I'm Peter.
Yeah, please try to speak loudly.
Oh yes. For this case, I will do magnetic resonance spectroscopy. I will check the Collin and NAA ratio. And then I will do the NRI TRS sequence, so we'll make sure that there is bleeding or not from the metastatic bleeding.
Audio was very bad. I understood that you do spectroscopy. What else? Spectroscopy, okay. Well, the thing with the spectroscopy is that in the cyst, you will not have a reliable answer. You will not have reliable results. So you have a very small lesion to do a spectroscopy, but it's an option. Why not? What was the other stuff? I did not get the other stuff. Okay. I think we proceed a little bit. I tell you what we did. So we did fiber tracking. We wanted to know where could we approach this lesion? And this is just one axle, but you see that all the motor fibers and all the fibers from the sensory area, they go medial or left of the lesion. So what would this mean for you in the planning of the next case, of the next step?
Okay, we have Francisco again. Yes, Francisco.
I think we can choose a paralateral approach to the safe entry zone.
Yeah.
Could you hear
So
me?
what are the options? If you have a brainstem lesion, we go back. Usually it's a very safe, you have a suboccipital midline approach here, but this would mean probably that you have not a direct access. You can come endonasal, not just next to the basilar artery, but there's a lot of tissue here. And then you can come from the retrosigmoid here. And there's a very thin parenchymal layer between the cyst and the subarachnoid space. So I think would be a good option. And the fiber tracking supports that we come from the retrosigmoid above the trigeminal nerve is probably a very nice approach for this lesion. Okay, so what can we do now? What would you do with the next step? Let's say that we did CAT scan, thorax and abdomen, no finding. And patient has mild symptoms, but has significant lesion. What is the next step? You do wait and see, you go for surgery. What is in favor of wait and see? What is in favor of surgery?
Okay, Peter is saying, how about a stereotactic biopsy?
Wow. Stereotactic biopsy in a cyst. I think the likelihood that you don't get a good result is quite high.
Okay, Khalid, yes, go on.
Yes, I think wait and see is not a good option for this case because it is a hemorrhagic lesion and it has bleed. And there is compression, some compression is there. So it might bleed again, and this is not a good thing. Now the patient is having some neurological dysfunction, but not major. If she had another bleed, she might be more disabled. So I think surgical intervention to find out to release this cyst and take that solid part from a retrosigmoid approach, right retrosigmoid approach would be a good option.
I agree. So I tell you what our thinking was. Our thinking was first, we don't think it's a glioma. It's too sharply, demarcated. So from the brain. So I think it was either cavernoma with hemorrhage, either hemangioblastoma or hemorrhagic metastasis. So then we looked at this, which is a little bit against metastasis because she has no edema. And the hemangioblastoma nidus is usually sharply demarcated. It's not, but it's don't matter much. What is in favor of doing the procedure now, even if you think it's no metastasis, is that you have space for manipulation right now. The cyst might be a post-hemorrhagic cyst, whatever the reason for the hemorrhage was. So in this cyst, you can manipulate, and when you are within the cyst, you don't harm the brainstem. So I think if you plan a procedure, probably this is the best time. If you think you don't have to do any procedure, then of course you can wait and see. And then we see here that this is a very nice corridor to come above the trigeminal from the retrosigmoid to go in. Okay, so this is what we did. I have to apologize about the quality because our HD camera system was right under restoration, under service. So we have the standard definition microscope. We did a microscopic approach. I'm don't think that this is a good option to do an endoscopic approach because you have to do a lot of manipulation. So we open up the basal cistern as usual, then we go in and we expose the retrosigmoid space, the cerebellopontine angle. You see the caudal cranial nerves, you see 7 and 8, a small adhesion here or even a slight vessel, and then you go in there. We use almost always semi-sitting. You see here that this is a patient is not very obese. You see this is the sigmoid sinus pulsating with every breath. You see that here very nicely. Here is the trigeminal nerve. It's right above the trigeminal nerve in the trigeminal nerve entry zone. And here actually, this was the approach. We see a little bit of a hemorrhage from this adhesion we just opened up. So the adhesion was a vein. And then we put in some tackle seal to glue this. I think this is a very helpful tool if you want to do semi-sitting surgery because it immediately occludes all areas for embolism. Good. So now we proceed with the procedure. For orientation, this is the upper part, is the cranial, caudal. This is the cerebellum, and this is the petrous bone. Then we use navigation. In these cases, I think navigation is very helpful because you really have to do a very focused approach and very focused opening. You see we go into the brainstem right above the trigeminal nerve. Resolution is, as I said, not optimum, but here you see the trochlear nerve. So trochlear nerve right between 4 and 5. And now we open up the cyst and you see immediately this is an old, subacute hemorrhage. Subacute hemorrhage, and then we evacuated this hemorrhage. Still at this point, I was not sure what it is. Still think maybe metastasis. I did not think about hemangioblastoma that much anymore because in my experience, they are not that frequently hemorrhagic. They bleed a lot, but in the cyst, hematoma is rare. And then we went in with the endoscope, 30 degrees endoscope. And here you see the lesion. Oh, this is the lesion. This is the solid part of the lesion. You see that the cyst itself looks quite calm. So not a really acute tumor with progressing, with the risk of progression. So we opened up a little bit more posterior to have a better access to this lesion. And then we just grab this lesion and we circular preparation. Unfortunately, this is not very good to see, but it was very firm. And now you see that it's a typical cavernoma, very typical cavernoma appearance. Of course, in these cases, when you have not good access, I don't try to really take it out completely, that you don't have to come back and look for remnants. And this was a good case, so we took it out completely. Send it for histology. Histology turned out to be cavernoma. And at the end of resection, There's maybe some tissue here. We went in with a 30 degrees endoscope again. Always as much as you can do without endoscope we do, and then we go with an angulated endoscope to rule out for remnants. In this case, actually, the cyst reduced in size immediately after evacuation. You see here, this is a 30-degree scope now, and you just look around whether the lesion is completely resected. It's a nice 360 degrees view. You see that there are no remnants, no active bleeding. I think this is an optimum case for an endoscopic assisted skull base procedure.
Very nicely done. Any
This
questions?
is the histology. This is the cavernoma. Histology revealed cavernoma, as I said. And this is the post-op CT. And this is the post-op MRI from today. Patient actually is improving, which is very unusual. Usually you're happy when they stay the same. But patient has improved with a gait ataxia. Trigeminal numbness remains the same. But you see here that when you compare this, that the parenchyma of the brainstem has much more space than before. And because of this decompression of the brainstem, I think that she's improving so much. Any questions?
Okay, any questions, man? If anybody has any question, please raise your hands. What is the trick for going in the delicate areas like that? And would you always do tractography before you go in?
Well, to be honest, we always do it now. Has it changed our idea of the approach? Never. So if you know the anatomy, I think tractography is not helpful. You not need it. If you don't know the anatomy, it gives you an additional idea, what you all not know. So we do it routinely, but we have never changed the idea of our planned approach when you use tractography in the brainstem. In some other areas, well, but here not, never.
Okay, the question is from Seema Sharafat is, could we have treated this conservatively?
Well, there are always two sides. If you have another hemorrhage, it's very unlikely that this patient will stay with his mild symptoms. So probably she has much more symptoms. And we talked to the patient because she's 62 years old, but right now life expectancy in Germany is for a female 62-year healthy person is about 85. So she has 23 years to go statistically. And this is a likelihood of probably more than 50% that she has another hemorrhage. So she wanted surgery. But there's an option. I have young patients with the brainstem cavernous hemorrhage who are on a wait-and-see basis. They come actually every 6 months for MRI.
Okay, brilliant. What about your position of the patient? Can you do this not in semi-sitting, but in prone position, or could you do it in park bench position?
Probably here it's possible. It doesn't matter really much. I mean, you need to drain CSF. So if you have a problem with this, I would do lumbar puncture or EVD. But then in such a lesion where it's not, you don't have to deal a lot with the bleeding. You don't have a huge lesion where it takes time to prepare all the cranial nerves. Probably it doesn't matter much if you do it semi-sitting or in a park bench position.
Okay, what about if you, onto your tractography, if the fibers were going right in front of where you were supposed to enter?
Well, as
What
I
would you
said,
have
I've
done?
never had this. No. I mean, there are cases when it's right in the center. Let's pretend that the lesion is not here, it's right here.
Yeah.
Then we just don't recommend surgery. Okay, so if there's a high risk for the patient, we don't recommend surgery.
Okay, we have Dr. Medal, who's gmail.com. Sorry, please tell your name and where you're from before asking a question.
Yes, yeah, I'm from Monterrey, Mexico. And
Okay.
my answer is about the, do you consideration the endoscopy only in this case?
Well, endoscopy only is, the thing is, in the beginning, you're not sure what you really have to expect. I think endoscopy only in lateral skull base, we only do in microvascular decompression. We basically always do endoscopic assisted in all other lesions. Some very small acoustics we have done with shear endoscopy, but as soon as you need a lot of manipulation, you're not sure what to expect, then we do microscopic with endoscopic assisted.
Okay, thank you.
Brilliant. Any more questions? We have Adnan Khalik. So Adnan, please tell us, sorry, it's Anwar Ahmad. Where are you from? And what's your name, please?
Hi, Salman, from UK.
Yes, go on.
Salman from UK. Just want to ask, take a home message for this, because as Dr. Jocham has said, it is not a metastatic lesion on the MRI because there's no edema. It's a very classical history of cavernoma. So do we need to investigate it as a metastatic lesion, or it is just extra out of the box thinking? Because sometimes in a health service where their finances and extra investigation cost more to the patient, can we not plan just with the MRI that this is cavernoma and we should go ahead with the surgery in the safest, earliest possible time?
To answer this question, we did not do a thoracic and abdominal CAT scan.
Yeah,
we did not.
Because this is the message I want to get clear, because people will think it's
I
always...
was very, but our radiologist said that they think it's hemorrhagic metastasis, and I was pretty sure that it's not.
Yeah, because the lesion itself defined itself. There's no edema. It's very well defined. It is
also the clinical condition of the patient is by far too good for metastatic lesion in the brainstem.
Okay, thank you very much to clear this point, because I just wanted to have that in.
Yeah, but you know, it's not wrong. The thing is, if you have done, we do quite a few of these brainstem cavernomas. So if you're not that experienced, this is a risky surgery. And in many cases, the patients they have at least some transient deterioration. So I think you have to feel comfortable that you proceed for surgery. So if you're not comfortable, do more diagnostics until you are comfortable.
Second question, do you need to do neuro monitoring in these cases?
Well, in this case, we have our standard cerebellopontine angle workup. So we do facial and trigeminal nerve, EMG. We do acoustic evoked potentials, and we do sensory evoked potentials. I don't think that you really need this if you do park bench position, but we did it, we did all these 5 things.
And what is your surveillance for these patients? How, when you will do your next MRI or anything, or you will just leave them because you have done a complete excision and you have seen that there's post-op MRI done recently?
We usually see them on a yearly basis. Why yearly? Because I just think that the rhythm of 1 year, 1 MRI is that this is a rhythmic thing. This is easy. If you do every 2-3 years, they usually come after 8 to 10 years.
Okay.
But it's not mandatory. It's very rare. It's very rarely you see a recurrence. Very rare.
Thank
I
you.
don't think that we ever had a recurrence in the brainstem lesion. We had a recurrence in the spine recently, but it's the only one I remember.
Okay, brilliant. Any other questions, comments? Okay, I think it's time. Joachim, that was wonderful. We enjoyed that. That case was really mouth-watering, but at the same time, heart-wrenching for some. And the good thing is we had a beautiful result. We have somebody from Indonesia writing that, thank you for a beautiful case. Do you think we need to be drilling more in these cases along the mastoid bone to get a better view of the pons?
No, I don't think that drilling is important. The thing is, you have to drain enough CSF, and this case was good because she has some atrophy of the cerebellum. Because, more or less when we go back, let's go back to the video. Can we go back to the video? I see you now. What has happened?
So if you screen share again.
Can we, I have to do this or you do it?
Imad,
you have thrown me out.
Imad, can we? KK Turel has just come into the thing. I'm sure
you see it now?
Yeah.
You see here that this is the tentorium. This is the tentorium. This is trigeminal nerve going in Meckel's cave, and this is the petrous bone. So it's almost infratentorial supracerebellar approach. It's something in between shear retrosigmoid and supracerebellar infratentorial. So there's no need for any drilling.
Okay, there's another question by Peter who's asking, what about planning the resection for this lesion using pre-trigeminal zone as a brainstem safe entry zone?
Well, in my experience is that if we go right at the area where it's the lesion is as close as possible to the surface of the brain, this is usually the safest area. And in here, the depths of the surgical opening of the brain stem parenchyma was maybe 1 or 2 millimeters. Right then, we immediately opened the cyst.
Okay, brilliant. Do we have any more comments? Or we just wrap up now? Okay, that was Joachim. You want to say a few last words before we have Khalid again?
Well, thank you, everybody. How many attendees we had?
We have gone up to 175. Khalid is again. Yeah, Khalid wants to say something again. Yep.
Yes, yeah, it just came to my mind whether we can use intraoperative ultrasound to locate the entry zone in such case if we don't have a navigator, for example.
The problem with the ultrasound is that at least the ones we have, which really gives good quality results, the problem of those is that they're too big. You cannot bring them deep in the surgical field. It doesn't look like it, but the surface of the brainstem is 6-7 centimeters from the dura. It's quite deep, and it's very difficult to bring it down with the ultrasound. So in my experience, the ultrasound is a good option for everything where you can have, an intrinsic lesion and you have the head of the ultrasound right at the dura. But here it's not helpful, too much air. Okay, more questions?
Okay, last question. Last question is from
Fuzzy.
Yes, Fuzzy. Where are you from? Hello? I think he's disappeared on us. So let's go to Francisco again.
Hello. What do you think about the pretemporal transcavernous transtentorial approach for ponting, for the pons?
Transtentorial, what approach? Transtentorial?
I'm sorry. A pretemporal transcavernous transtentorial approach.
Pretemporal.
Transtentorial cavernous? Why should
in
you
the
do such
in
a
the
difficult
journal of
procedure?
in the neurosurgical journal, the author maybe is a guy of of China. He published this approach for cavernous malformation
Well,
in the pons.
transcavernous surgery is a very, very risky surgery in any case. So if you have the different options, the safest way is to come from posterior. If you have usually the standard lesion in the brainstem, you come the suboccipital midline approach. Then the next most likely approach is the one we have seen today on the retrosigmoid. And some you approach with endonasal transclavial, but this is already quite difficult. Transcavernous approach, I don't think that this plays any role in the treatment of these cases.
Okay, I think we're going to wrap up here. Thank you, Joachim. We're just going to go for what we have on going on in the next couple of days.
One more second. I have to introduce again Mrs. Radke here. She's one of our medical students. She prepared the case for today. I think you should give her an applause.
Okay, thank you very much. So before we're going to come back to Joachim at the end. It's we have tomorrow Roton Neuroanatomy course by our residents, and tomorrow it's going to be Dr. Yusufson, who's our chief resident as well, and with him would be Azam Ahmed from Wisconsin and Hassan Sayed from Charlottesville and Chandrasekhar Deopujari from Mumbai, and we have this tomorrow at 5 o'clock. Imad, have you got something for Sunday? We have Doug or Paolo is actually not joining him, so we will have somebody else presenting some cases along with Doug. Doug is going to be talking about management of lumbar disc prolapse, and he does his own way. And he's going to show some cases and tell you how he decides which case to do with what. Maybe it might be worthwhile, Joachim, if you could get Benedict to join us and maybe talk about endoscopic discectomy in this.
Which day is that?
It's Sunday, so it's going to be.
You do webinar every day now.
No, this is.
It's like Pablo Picasso in his last year.
This is basically what we had was for the anatomy sessions we have started, which are regular, and IFNE endoscopy sessions are regular now as well, every alternate weekend. So because of that, now we have 6 or 5 days a week webinars. I won't be there on Sunday, so that's because we have another meeting at the same time. But I think Dagor is going to take over. So you're most welcome if you want to come and share the stage with them.
No, it's too much.
Okay, ask Benedict if it's possible, and we will have him in there. Okay.
I can ask him.
Okay, and on Monday we have Salim of the Roof, who's going to be talking about anatomy of skull base, and this talk is meant for junior neurosurgeons and residents and trainees. And Pablo Gonzalez from Spain and Athar Inam from Karachi will be joining, who both know him well. So, and then we have a couple of other interesting cases to follow that. So Joachim, for your last words before we wrap up.
Yeah, well, thank you all for joining us. I think we had an interesting lecture by Professor Lee about the shear endoscopic treatment, mainly about microvascular decompression and some tumor aspects. And well, thank you again also for this vivid discussion, because there's a lot of different options if you have a brainstem lesion. It's I don't say that it's right or wrong. Of course, at the end, when the patient comes out, has no new deficit and is improving, then surgery is the right case. But this is not always the case. So it's decision making, and knowing your own skills and limits is very important. So thank you, Salman and Imad, for organizing all this. And well, see you soon. Huh?